anybody have anything to say? Okay. So when we look at therapeutic exercise or any sort of treatment, we look at those models of disability and functioning. So you remember the Nagy model? No. Okay, so here's a test of honesty. Who read chapter 1?
So
Part of it.
Not in
parts?
completion.
Parts.
I
Yes.
tried to. So I did try to.
Like-
What happened?
It was a lot.
It's a lot.
It's just a lot.
It's like a lot of things for like a PT.
Took about 5 hours.
It's just
Yeah, I think there is some diagnosis stuff, but you need to understand how a PT gets to decide what ICF or codes that they use, and then you have to decide what codes you're going to use. And if you don't understand the pathology or the disability or the function of the person and how they got to that point, you're going to have a hard time describing your treatments, whether it's neuromuscular education, whether it's strengthening, whether it's endurance, even breaking down gait. When you're doing parts of gait, are you really doing weight shifting for balance, or are you doing it as a pre-gait exercise, or are you doing it for feedback, are you doing it for cognitive awareness? You have to understand why you're doing something to be able to document it so somebody else understands, so you understand what is wrong with the person. So that's why these are important. Again, they're not just terms that I'm trying to torture you with.
And let me add for the ICF that PowerPoint that's in Neuro, chapter 1 and 2, that we didn't review, is reviewing the ICF. So you guys can look at that.
And you've also had it in pathology, and you had a little bit in orientation, kind of skimmed over it, because I knew we'd be going over it again. And you'll be seeing it again and again. So these are the other ones that it's kind of progressed into the ICF. So impairment of body structure, function, activity limitation, participant. I turned it around. Yeah, you can just leave it because I turned it on the back.
Okay. Oh, okay.
So they can see me.
Circles.
Sorry to make you dizzy. And you guys should just have your PowerPoint open. So can anybody give me an example? Because I know you've had this 3 times already. So if we were to take a patient, name a diagnosis.
Osteoarthritis.
Arthritis. So impairment of the body structure. What would that be? Okay. So you know the physiology behind the arthritis, and what impairments does that cause?
Reduced range of motion.
Reduced range of motion. And if you have swelling, you have
Inflammation.
pain. Pain is an impairment. Yep.
Weakness.
Weakness, impaired muscle performance. So if we have weakness and impaired range of motion and pain, how does that relate to their function? What things do you think would be impaired? Like?
Even getting out of bed or.
I guess it depends on the body part, right?
Yeah.
I was thinking the knee, but. So we're thinking shoulder. So that's why that's important. Knowing the joint. Okay. So is there the right or left shoulder? Yeah. Left shoulder. So they can brush their hair with their right. What else?
Driving or
Hmm?
driving?
Driving. Good.
Getting dressed.
Getting dressed. Lifting, reaching, riding, bathing, toileting, getting out of bed,
Toileting is big.
carrying, feeding, almost anything with your shoulder. So, then we have participation restriction. What restriction would they have in participating in what? Okay, so guys jump into the sports, but yeah, Participation in recreational things, tennis, basketball, any overhead stuff, swimming.
Community,
And, you
go to
know.
the grocery store.
Why?
Can't drive.
Okay, so difficulty driving,
Getting
And she can't-
groceries?
get her groceries.
Like actually like carrying your groceries around?
Carrying the groceries, good,
Like doing your laundry.
good. Doing laundry. So she can't, the way you need to look at this is you have those impairments that affect certain impairments functionally. So we look at the range of motion and all those things that we've talked about. Range of motion, strength, balance, proprioception, integument, all of those categories that we looked at. And I put on bright space the minimum required skills, remember that? Minimum required skills in the PTA, we went over a few times. So when we go into that, we'll go into it Thursday a little bit. And it breaks it down into all of those things we assess. That's why we do girth, around joints to measure any type of edema or inflammation. That's why we do observations with our eyes. For posture, for looking at integument, is it red? Is it swollen? Is it hot? Temperature? And then we do the other typical goniometry measurements, strength measurements, balance, and then we do objective measures, which look at either function or specific things like balance tests, which again we'll get into later. Those things relate to function. So if somebody can't drive, they can't get dressed, they can't get out of the house, they can't get their groceries, they can't get to doctor's appointments. So we need to take those things into consideration when we're doing our plan. So we're going to increase the range of motion and decrease pain so that they can improve their ability to dress and drive to participate in whatever it is, whether it's being in the community, whether it's playing with their grandchildren or their children, it could be anything, going to work. They need to get to work, they need more shoulder motion to be able to drive to get to work, to be on their computer. So you need to look at all of the components, because as we look at goals, we need to make those links. So when you do your documentation, that's what we've been kind of missing. They had improved range of motion in the shoulder. So, how much? Why? What does that help? How does that reach the goal? So again, when we start that documentation, try to think of all of those sides. So impairment, then the function or activity limitation, and then the participation restriction. What is therapeutic exercise? I know Emma knows. What is therapeutic exercise, Emma?
It's exercise with the intention of improving or optimizing like someone's performance or how they utilize their body.
How is that different from what you do?
It's not strictly like aesthetic or performance based, so it's more for functional activities and improving their daily life.
What's the difference between performance and function?
Right. Depends on the individual. So maybe there is no difference
Is
depending
there?
on the individual.
Natalie, is there a difference? Performance and function.
Yeah,
If
I
you
just
sort of read the chapter, you should know.
yeah, function is like just living your daily life, and performance I would say is like going beyond that.
Okay. So I would say that too. Function is the things that we do every day, whether it's a B ADL or an I ADL. Next time. So remediate or prevent impairments. All those impairments we're going to try to improve. As they improve, especially when we get to chronic conditions, we want to make sure that they are not happening again. So improve, restore, enhance physical function, prevent or reduce health-related risk factors, optimize overall health status, fitness, or sense of well-being. Why do they have that in there? That's more what Emma does. Why does that matter? Optimize overall health status, fitness, or sense of well-being. Why? Like, who's so quiet?
I was thinking more like optimized meaning that it fits that person's state of health rather than, at fitness I feel like it's kind of like more like, it's not, well, I don't think it fits the person's health more like doing something like their ex where they have to do examinations and everything to make sure that whatever they're doing is optimized for that person.
I see where you're going. Alice?
I was thinking that it means kind of like when they came to you, they weren't really at their healthiest, but you can teach them things to get them to where they were and beyond, make them a healthier individual.
How do you think we do that?
Just by even just little things like posture or teaching them that, you know, their weight affects like their joints and that type of thing. And
Patient education.
yeah.
So we can take these things, improve, restore, enhance physical function by attending to those impairments, which attend to the function. But let's say we have a lateral epicondylitis and somebody's sitting at the computer. You can fix this tendonitis, but if you don't fix anything else that caused that, then you're not really helping them optimize their overall health status, because it's just going to reoccur again. So it's the same thing with arthritis, it's the same thing with a rotator cuff tear, ACL reconstruction, ankle sprains, like so many things. Once you injure a tissue, and we'll talk about tissue healing and repair, that it's really never as strong as it ever was, except for bone. So there's always going to be some instability. And it wasn't just because that ligament or that tissue was weak, it has to do with everything, the whole chain, the whole kinetic chain. So this is how I split that up. So pathology can be any disease, disorder, condition, or abnormality. The impairments are all of those things: cardiopulmonary, integument, musculoskeletal, and neuromuscular. And then we have the functional limitations, which can be physical, psychological, or social. It doesn't just have to be wiping your butt, even though that's important. But there are tools. And then the disability, the needs, desires, and expectations. Why do you think I'm talking about this, Idali? Why do we care if they go back to tennis? You can wipe your butt. You can brush your hair. Yeah, quality of life. Is it just about being able to get dressed, drive to the store, get our groceries, and come home? If you've learned that during COVID, that is not all we need, right? So we can use this in our goals. We can use this in educating them, educating our patients, and getting their motivation up. So here are all the components of therapeutic exercise we will address. All of them. The cardiopulmonary we'll probably do more in the summer, but we address all of these, not just strength. And everything affects everything. Corinne, what is stability?
It's like when you're moving or staying still, like the ability to like keep your body in the position that you want it to be in, like to use strength and balance to like.
Rochelle, what's stability? I'm not saying you're wrong. I'm just getting a second.
I think it's just like that, like your ability to just hold your body still and like almost like in place, I
Like this?
Like an
It's
uncompromised
like
position.
Yeah.
Ability to resist change.
Ability to resist change. Anybody else?
Consistency.
Interesting way to put it.
What did he say?
Ability to resist change.
That's just how I've always thought.
Maybe to
stability.
respond to change. Interesting. Emma, what do you think? From the personal trainer's mouth. What is stability? I can't pick on you. I'm sorry.
You're
Alright,
the
never
personal
mind.
trainer.
Okay.
You're the personal trainer.
Jake, what do you think? Stability.
Stability, consistency, maintenance, maintaining
Maintaining, okay. And now I'll go to you, Emma. How do you think that would be affected by flexibility or mobility?
Well, I think like for specific joints, excess flexibility can lead to decreased stability.
Good. And then, Leah, we haven't heard from you. How do you think that hypermobility, which leads to less stability, is affected by muscle performance, which can be strength, power, or endurance?
I would think that if you have less muscle, that you would have less stability. If you're more flexibility.
But if we have hypermobility because our muscle is really long, which means the joint is not protected. So are you saying that would lead to less strength?
It would be less stable.
It would be less stable
If you have
because
less-
of the mobility.
Yes,
Okay, but how does strength relate to that?
I figure if you have more strength, then it's going to help to keep your joints closer together, so you don't overextend it.
Good. So if you have a really long muscle, so the joint is unstable and not able to hold itself, if we strengthen, we can create more stability. And what do you think, Leonda, neuromuscular control has to do with it, or coordination?
Has to do with stability. Well, I guess one of the first ones I had with stability was actually thinking of probably as stasis. So actually, which includes actually being able to adapt to things to stay stable. So neuromuscular control is, really involved in that. Biochemical, electrical aspects.
Through what? What is sending those messages?
The neurons, the brain.
What is it sending it to? I know I'm looking at you.
That's fine.
What is it sending? Because I see that you read. And I know you read neuro too, because I saw the highlighting. See? So I know you know, so let's just go with it. I mean, I don't expect you any to really answer this, but I wanted to start putting them together. So neuromuscular control would be neurons sending information to something to help with stability. To other neurons. And then to what structures? What structures would help with neuromuscular control or coordination? Do you know like it's
skeletal muscle.
Yeah. Neurons can be sent to that. Those. What else? What helps me do this? You're good. That's one system. Very good. See, she listens.
See how it's all
What else?
tied?
What else? Ooh.
Vestibular.
Stability of what? My joint? On the talus on the calcaneus? What tells it it's stable or not?
Like your proprioception.
Okay.
Like
so
where you
if
are
it
in
starts
space?
to move a lot, what is responding to send information to the brain to send it back down to correct it? And again, I don't expect you to know it, but I want you to think about it.
Frontal cortex.
Vestibular is another system. Neuro, vestibular, skeletal. What else?
Motor neurons.
Can't hear you.
So the motor neurons. I don't know.
Motor neurons.
Central nervous system.
Yes. Endocrine? Probably not. Those are more like physiological.
Like the feedback from the, like something.
Yes, something.
I just said that.
You know, there's some receptors.
Like the
somewhere.
proprioception feedback
Yes,
from the
proprioception.
Okay.
Good.
I was like, it's right.
You said that.
We also have our ligaments too.
I said vestibular.
Our ligaments help keep our joints stable. So what about cardiopulmonary? How does this fit in? So So we have this unstable joint because of the really long muscles, and then we strengthen to give it more stability, and then we send more information through those motor neurons so that our skeletal muscle reacts. What does cardiopulmonary have to do with it?
You have to have the oxygen.
ATP.
You have to have the oxygen to
Need
do it.
oxygen for all the ATP.
Oxygen. Good. What do we use
Yes.
this for? Why do we stand on one leg? Besides torturing your clients,
Balance.
walking.
Awareness.
Walking slow. Depends location, right? But whatever that treatment you're doing leads to something else. They don't just go home and brush their hair on one leg. I mean, you'll tell them to do that for their exercise, but that's not the end what we want. The end is we want this so that they can do what at the grocery store? Where they can walk from the parking lot to the car, into the store, throughout the store, back to the car, back to their house, and still finish their day with some sort of endurance. They need that cardiovascular endurance. So all of these affect everything. And yes, you do need the oxygen delivery too. So there is a box in the therapeutic exercises, and you can let me know if any of these boxes are not on there, or are missing, or if the pages don't correspond, because it might not.
They
Because
don't
I think I
allow.
have the 5th edition.
They're all there, but I think they're just like off by one, maybe.
Yeah, they're all beautiful. Because by the time I ended doing this PowerPoint, it said, by the way, chapter 10 and 11 don't exist in the future editions. So, we'll have to work with it. Okay, types of impairments, we kind of already went over that. So give 2 examples. 2 examples of an impairment. Come on, quickly. We have lab to get to. The fun part.
Traumatic brain injury.
Huh?
Traumatic brain injury.
No, impairment. Not diagnosis. Hey,
Decreased range of motion.
hey, decreased range of motion. Kind of already went over these disability activities. So those functional impairments, reaching, grasping, bending, squatting, lead to the disability of these activities: school-related, home management, caring for dependents, recreational, community responsibilities, and self-care. Clinical decision-making. Not clinical. What is clinical decision? Making the best choices for your patients. What do you think, Evie? What is clinical decision making? Okay, making a decision or making choices based on a specific situation. I like that. Anybody else want to add one? Critical thinking. So how do we critically think? This has been a challenge to try to help you learn this.
Maybe think.
Thank you for looking at my screen. I appreciate it, and I'm not being sarcastic, because that is choosing the most recent research that we can that's available and assessing it. Do you guys know how to do that?
Yes.
Kind of. Yes.
All research is not good.
That's not true. In your modules, I have lots, like 8 articles that are good. It's just that you chose the subjects that didn't have a lot of research. Why? But why? Why did you choose subjects that didn't have a lot of research?
Those are the interesting questions.
Yeah, those are the things we want to know about. Those are new, like the kinesiotaping, and the dry needling, and the electrical stimulation. Do you think there's good evidence on physical therapy in general? That's why I didn't let you look that up.
Yes. For sure.
Go to the end of your chapter, Ben.
Yeah, there's
There's like 6 pages of references.
202 references.
There's 2 references?
202.
Oh, 202 per. How many chapters?
One.
Do you think there's evidence for physical therapy?
See.
Do you think there's evidence for all these weird little models we make you think about?
Yes.
And it's changed over the years. Going back to 1010, where did physical therapy start? What level of education?
High school.
Nope.
I think a certificate. Wasn't
Nope.
It's a bachelor's, I thought. I know it's a bachelor's
Hey,
at some point.
Corinne, we're at war, and there's somebody that's hurt right here. Come and help me.
Got it.
Wing it. Reconstruction aids. Remember that?
Yeah.
And then where did it go?
You say PT or teachers?
Well, the doctor.
It went to
PTs are for-
polio. I think what you mean is there started to be more, and then we looked at it more critically because of the polio epidemic. Is that what you said?
It went to
I'm not sure we're all there.
polio.
Trying to remember.
So then it went certificate, then it went associates, I think, and then bachelor's, and then master's, and now a doctorate level. It's a long way. What is a DPT? Why do I get that D in front of my PT?
You can diagnose certain systems.
All PTs can do that, even if you have a bachelor's.
So you can do some like care without having to have a doctor referral?
All PTs can do
She
that.
had to write it.
What makes me different than other levels of like a bachelor's or a master's?
Do a dissertation.
No, that would be a PhD.
Doctor. You're a doctor.
It's more money and more education. That's not really what she said.
I'm like, oh.
More education on what?
Everything.
Research. Research. What does that mean? It's these one-word answers. Throwing me off.
Evidence-based practices.
Evidence-based practice. Thank you.
You went back.
Oh, I went backwards. Oh, we went way back. Okay, here we go. So a DPT is an entry-level doctor of physical therapy. It's the same level of education as a dentist, an MD, a podiatrist, what?
No, because nurse practitioners only have
No,
like 2
that's a good
years.
question. So it says that I can diagnose whether somebody really needs physical therapy. I would be able to refer somebody out when they're not appropriate for physical therapy. And you're gonna learn I have lots of handouts on red flags, which you guys are gonna be able to go, oh, that's not really back pain. That's not really shoulder pain. Because I've looked at it this way, and this is really coming from your lungs, or your pancreas, or your kidneys. So, as a doctor, I become a first-line health professional that somebody can come into without a referral from an MD, and I can go, okay, you tell me you have back pain, and I can work through to decide whether you really have something I can treat, or you need to go see your renal doctor. Does that make sense? And then the evidence-based practice is kind of just where the whole profession is going. There's where schooling is going. We want evidence to back up the things that we do. Do you know why it went in that direction? Julie, why did it go in that direction? I know. They don't like to be picked on. I remember a parent did it to me. Hey, I wasn't really listening. Consistency. Okay.
The general public can understand what we're doing or why we're doing it, or that even conceptually see it as a
Scientific.
skill.
Science. What do we keep hearing from the news media?
As the FC says, just kidding.
Follow the science.
We're obsessed with science. Obsessed with it. And I think it's just, people want to prove it. They want proof that doing this strengthens your quads most effectively. And there's thousands of ways to strengthen and work on coordination and do all these things. That's what's gonna make your jobs fun, all the creativity behind it. Unless you're not creative, then you're gonna be tortured and bored. So,
Well, Joanna, I was gonna intersect it, you know, thinking about what we talked about this morning. As, you know, as long as humans have been here and they've stubbed their toe, we've always rubbed it. But now we have to prove
how that works.
how that works.
Right.
Why is the rubbing feeling it, making it feel better? Science now is telling us that it's not just something the humans made up, right? It's actually a neurological pathway that stops that stimulus. Again, we've always done it, but now we have means to prove it, that this is how it works, right?
And I think a lot of people, again, like the first day I told you, they don't know what we do. And I think you still don't know what you're going to go do. But that's fine, because we're gonna get there and you'll see. But you can't just go to somebody, well, I'm gonna do these joint mobilizations and this stretching, and we're gonna get you playing baseball again. How's that gonna work? Why moving my bones? How is that gonna work? And you're gonna be able to know. Alright, so this is the process we go through, right? That examination, history, systems review. This is done by the PT, tests and measures. But you should be able to look through all of these and put things together just as well. The evaluation part, you interpret those findings. The exam and the tests and measures showed this, so I'm diagnosing you with this. And there's different kinds of back pain, there's different kinds of shoulder pain, there's all these different structures, there's all these different things that lead to somebody having a disability or having all these impairments. So we have certain diagnoses, and then depending on the person, a prognosis, and then we develop that plan of care. So that diagnosis includes all of those things: signs and symptoms, impairments, functional limitations, and disabilities. How do we decide whether somebody has good, like poor, fair, good, or excellent prognosis?
Research.
What do you say?
Research.
No, it's gotta be, well, you don't have time for research.
So I have Kaya, and she has elbow pain. She's had it for 3 years. She's had 2 surgeries. She's had physical therapy 3 times. How do I decide whether she has a good chance of making gains, an excellent chance, or a poor chance? What are some factors?
Prior level of function.
Age, prior level of function,
Her state of mind.
mental or cognitive,
Her motivation.
comorbidities.
Lifestyle
Her-
habits. Lifestyle habits.
Lifestyle, okay. Anything else?
Her function.
Medical history, what does that mean? So you've had 2 surgeries and 3 bouts of PT. Not a lot of PT? Not 3 sessions, like you've gone 3 different rounds. Not promising? How do you know? What do you think, If you've had 2 surgeries, 3 rounds of PT, I didn't tell you what happened first. How do we know? How do we decide? surgery successful? Was the PT successful? Did she meet her goals last time? Were there any complications? All of those things. And everything you said goes into the prognosis. We take everything into consideration. And then we make goals and expected outcomes, frequency, duration, and discharge plans. Why do you think we're making discharge plans right after we evaluate and diagnose?
So you have an end goal?
Well, we have other goals. We have short-term and long-term. What do we need expected outcomes for?
So you know what they need to accomplish in order to be able to discharge.
Good. So we have short-term, long-term goals, and then we have, what do we want in the end? Yes, the range of motion may be full, the strength may be full, they may return to tennis. But what are the expected outcomes? Those are the goals. Do we always meet our goals? And Leah may have a different expected outcome than Jacob with the same diagnosis. And all those prognostic indicators or factors play into what are the expected outcomes as well. So I'm kind of spending a little more time on this because I really want you to understand how much PTs really think about their patients. Why do I want you to know that, Natalie? Not just because I want you to know how hard I work. Because who are you to me?
Like the PTA or the patient?
Yeah. Not in life, but in a clinic. Who are you to me? Who are you going to be to the PT?
Someone to help them achieve their
Teammate.
goals.
Do you need to know my thinking?
Yes.
Do you need to read my mind?
Yes.
You just need to look at the notes and the
Trick
evaluation
question.
and put together what I put together. And I leave you assessments and we have communication. Do you see where last semester came in now? Collaboration, communication. If Emma came to me and she's like, dude, like, this person is not getting better. I'd be like, can I have a new PTA? How could she come to me? That communication is so important. I know that's why we want you to practice this. Hey. And they wouldn't call me Dr. Ian. Joanna, this person, the range of motion is not changing. They're having more pain. It's starting to get more edema because I measured it by 2 millimeters in a week, and it's hot. And they fell on it last week, and they started taking this new medication. I'm really not sure what to do. How does that sound? Better than do. This person's not cool. I don't want to see him anymore. Do you think you're gonna like all your patients?
Yes, for sure.
I'm just like, well,
Optimistic. I like it.
So then that's where the coordinate, communicate, and document. You need to have proof when you come up to a PT and go, look, this person's not making progress. I need some guidance, or what do you think I should do? Not just like, you need to go back to your PT. And they don't even know why they're back on their schedule. They're like, what's happening? I thought you were seeing Emma. I don't know. I don't think she likes me. Because she told me. And then that also, the interventions are good at patient, client, instructions, and education. You're just going to be like, I don't know. I'm just going to send you back to the PT and not tell them anything? Not explain what's going on? How would you like that? Remember we talked about those skill checks? It's a mystery to the patient. Are you wondering what I just did? She's like, well, I know. You need to communicate efficiently. Not just blah, 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 blah. You need to be efficient. You communicate with the patient and with healthcare professionals and use the language as appropriate for those people. Okay,
And I was just gonna add that you need to know then why you're doing that treatment to be able to effectively communicate the reasoning, right, for that. Cause they have to buy into, they have to want to do what you're asking them to do, right? So even though, like we talked this morning in modalities, right, you're not gonna be the one assessing how much to pull on that traction, but you need to know how the PT got to that point, right? So when things are not normal in terms of like what you normally see and say, I wonder why she put this. You should know reasons why, right, in the back of your head. So when something's happening, not going right, you're gonna say, hey Joanna, you know, we did the traction and they had some, they experienced some pain that they haven't experienced at this, I feel like we should just cancel it or, totally just not do it anymore, or I feel like maybe we should back up on the weight, and then she'll say, okay, then she knows when you're coming, instead of like, hey, I don't know what's happening, I just did what you told me, and something happened. Because for that, then you're just the test.
Some of the handouts that I'll give you about the red flags talk about the role of the PTA and how to really have that communication, the questions to ask. How do you want me to proceed? Not, oh my God, what do I do? I'm so scared. How do you want me to proceed? What is it that you would like to do? Okay?
So
we
we give
did
suggestions to the PT.
Yeah, suggestions.
Yeah.
Because you see them the most.
Offer them your suggestions.
Your assessment.
So we were talking about the outcomes and the discharge planning, which includes the home program. We always send people away with instructions, handouts, web links, whatever resources that they need. And then if something stops, we always give them a referral, or you need to follow up with the surgeon, just as they're saying. And just be like, all right, have a nice day, see ya. Have some sort of plan. And I always say, if something comes up, or you forget your home exercise program, or you run out of the TheraBand, or your knee pain starts to come back, give me a call. Here's my email, here's the office number. Don't give them your personal cell phone number. So I think in the other class in neuro you got into the motor learning, so I'm not going to spend a lot of time on this. Do you go over the discrete and serial?
No, not those.
Not like cereal, like Cheerios, but cereal.
Yeah, we
The
do. I mean,
series.
we'll get there. I think that's, we're not there
We
yet.
can always go over it again too if we get kind of stuck. But with motor learning, there are specific things you can alter to create better motor learning. And so there's lots of different factors with the patient and the environment, how you give feedback. So there's all these different tasks, which again we'll get into a little bit later. And I'll be there the day go over it just to see if we need to add anything. So some of the conditions and progression of motor tasks, there's closed versus an open environment. Does this sound familiar? Has anybody done this before?
No, but read about
Okay,
it.
closed environment, which would mean the lights would be on, there would be no distractions, there would be nobody walking, no bells going off, there would be no distractions whatsoever. Closed environment. And especially when you're in neuro, this is important. Frontal lobe, there's lots of issues with distractibility, and they really need something that's closed, where there's not a lot of distractions. Then you can progress to being in the hall with music on, or being in the hall with other people walking by, because this is a whole different environment. And then intertrial variability, which means you can keep one task the same for several different trials, and then you can keep the same task in different environments, and then you can take the feedback close very consistently, and then you start spreading it out, and manipulation of objects while they're doing a certain task. This will make it more apparent. I have better examples when we get into some of our activities. So there's these different stages of motor learning. The cognitive is what to do. Sometimes you just have to tell somebody, this is what we're going to do. We're going to walk over here, we're going to pick up that coffee cup and put it down on the table. that's what we're gonna do. And you may do demonstration, you may just do verbal. And then after they know what to do, they may verbalize it back to you, and then you move into the associative stage. So they may go over and they're like, what was I gonna do? Don't remember. Or they pick up a glass instead of a coffee cup. Or they pick up a plate. So then you have to fine tune what they're doing. And this goes in all stages. It's not just neurological, it can be in sports as well. If we're taking a golf swing, this is how you do a golf swing. This is the first part, this is the second part, this is the follow through. Anybody a golfer? East Coast. So these are the parts of the golf swing. This is what you do. And then you can have somebody think about what they're going to do. And then you show them how to do it. And then you make adjustments with their weight shifting, with their arms, with their follow through. Then you change different things along the way. And then as the motor components go back and forth between the brain and the muscles, then it becomes more automatic. Then you give less feedback because they start to get a little bit better and a little bit better. This goes with everything. Teaching somebody a quad set. Come on, you can do this, tap, 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 we gotta do this, come on, keep going. And then 6 sessions later, okay, quad set. You do it. And you come back, do your first exercise, you don't even have to say what it is. It's more automatic. Alright, considerations. Let's get that part. So the feedback, there's different kinds of feedback, knowledge of performance versus knowledge of results. You did a great job doing that straight leg raise. Knowledge of results. You did the straight leg raise, but you didn't keep your knee all the way straight. Knowledge of performance is how somebody did something. Knowledge of results is how they did something and what they either did right or wrong about that performance. So it's just a little bit more. So the timing and the frequency will change. All right. What is that? Next time we'll get into a range of motion. Have a little ab exercise. Let's get in groups of 2. Somebody you haven't worked with before. Everybody stand up.
Worked with each other in a while.
Come on, kids, come on.
I think I have worked with